We have very limited time for moderated questions here. I'm going to only ask 2, and then we're going to go to questions and answers from the audience. So first of all, I would like to start out asking this wonderful panel, in terms of Harvey's impact question, what actions should we be taking, we as an Institute of Medicine, we as a healthcare system, to mitigate the effects of violence? Sarah, do you want to start?
Sure. I think one of the challenges that we face is that for many children, the impact of violence is hidden, and that the impact of it on their lives often doesn't play out for an awfully long time. And so I think one of the challenges that IOM can help us to meet is to educate both policymakers, scientists outside of the IOM, and parents about the need to invest early and to invest in families and to invest in things that seem relatively distal to the kinds of outcomes that we're trying to prevent. Because I'm not sure that that link is always very tight in people's minds. I think that's something the science can really bring to that.
Bob?
So to take several areas, first off, we have a war that is now returning to peace, which means we have soldiers returning home. The transition to home is a risk time in and of itself, particularly our Guard and Reserve soldiers. Secondly, when one asks about post-traumatic stress disorder as a national issue, remember about 33% of those exposed to a serious motor vehicle accident develop post-traumatic stress disorder. We presently have no mechanisms for screening and looking at that disorder in our healthcare system. We know from present data that only about 60% of people with PTSD ever get treatment in the nation, and it takes 12 years before they get that treatment. An approach that deals with PTSD as a healthcare issue beyond war is important for us being ready for any next disaster event.
Well, I know it's difficult for the IOM to take controversial positions, but it seems today there's 2 areas having to do with violence research in which there are pressure groups that have strong lobbying interests and hire lobbyists. One is gun violence and the other is media violence. And I think it would be useful for the IOM to find some way to do whatever it can do to try to counteract this pressure. I mean, we know now at least we can do research on gun violence again, and we've always been able to do research on media violence. But in both areas, there's tremendous pressure on what the results should be found by vilifying various researchers that find results that are unpopular with the economic interests and such things.
Darnell?
Well, I think we've already made a lot of progress in that regard. If you look back at what CDC was doing in the 1980s and 90s and compare that to the kind of perspective that people have now toward health problems in general, whether violence is a health problem, I think that we already have the groundwork laid for extending that. And I think that the IOM could easily extend the groundwork that's already there in place, and by also emphasizing that health problems from violence are not any different from health problems from cancer.
Perhaps working on the implementation of all of these wonderful study findings that we've been conducting, what might be one way forward also. My second question is in terms of health inequities, in terms of what difference health inequities has made in both in terms of what's happening in the violence, some of the causation risk factors area, and also in terms of outcomes of violence on people's health. And Sarah, I'll again start with you.
Well, I alluded to this. I think that one of the challenges is to understand both that violence exposure is a source of social stratification and that it then creates cycles of violence which reinforce and perpetuate those social structures. And so I think that the challenge for us is to identify where in the process we can interrupt them. And that's something that I think we need to accelerate at this point. The disparities aspect of violence, I think, needs to be a theme that many scientists can get behind.
So on the picture of disparities, let me highlight that war is endemic to the world. It's also endemic to our nation. That terrorism was present in the United States long before 9/11, and it is present in our inner cities. The idea that people can be killed because of drug abuse and that homes can be firebombed and one's children killed, as occurred in Baltimore, because one suspects that drug abuse is going on, is an endemic aspect of war that we have, regardless of whether our nation is overseas or present. Dealing with those issues, and in addition, the complexity of natural disasters, which overexpose those with lower socioeconomic means, true within our nation as well as the world.
I really agree with what both Sarah and Bob said. In fact, poor minority children are much more likely to be exposed to real violence, and we know that they have much more exposure to violence in the media. I mean, both of those are true. And, but those people have less power in society, less power to deal with any of this. And that creates great disparities.
Darnell.
Well, I think we often have to find advocates for the underprivileged. I mean, for example, the 1983 conference that I went to on youth violence was convened by the National Association of Black Social Workers. And they convened the conference because they were fully aware of the devastating effects of violence in the inner cities. So, just looking at this audience, I mean, just for me to just give you an analogy, I would like to see a few more black, brown, and red faces. And that kind of coalition building would generate the empathy that one needs for doing something about the problem. The same happened with the AIDS epidemic. Once there were more AIDS activists involved, there was more funding, they lobbied for funding, etc. But without their lobbying, there are questions as to whether the funding would have been there.
I agree, and I also think about the access to health care in terms of, particularly for poor people in this country, the lack of access to any kind of good mental health care. And if we're going to deal with some of these effects of violence, that has to be changed, and we have to increase that access. I'm going to go ahead and turn to the audience, and I'm going to take moderator's privilege and ask my co-chair, Mark Rosenberg, for the first question.
Well, thanks, Jackie. And I want to thank all the panelists for a tremendous presentation at the panel this morning, not only for what you presented, but for the work that you are doing and presented so clearly. I was struck by Darnell's statement that the problem of violence is going on, unabated, unlike the HIV epidemic, and it goes on, it's a chronic issue that we're dealing with. It's endemic and chronic. And each of you has presented an aspect of violence, violence against women and gender-based violence, the problem of violence against children, the problem of traumatic stress disorder and post-traumatic injury, violence very prominent among our soldiers and returning vets, and the contagious aspect of violence. All of this goes on in a context in which guns are readily accessible. How does that make the problem and the aspect that you deal with, each of you, worse or different? How does it contribute?
Well, I can start out there. One of the things we do know, thanks to a great analysis by Jim Mercy and some of his colleagues, was that in states where there is a clear mandate and implementation of gun regulations in terms of possession of firearms by known domestic violence offenders and those who have an order of protection out against them, that when we remove guns from those known offenders, as our laws and statutes allow us to do, and it has been upheld by the Supreme Court in 2009, we find fewer domestic violence homicides, especially firearm homicides, both of men and of women. And so that's an example of policy that is present in most states, but is oftentimes not fully implemented. Sarah, do you have a gun?
Well, I think going back to what you said this morning about how can we find common ground that allows for us to appreciate the rights of Americans to own guns, but also that keeps us safe. And I think one place that we haven't talked an awful lot about is potentially the area of adolescent suicide, and talking about how do we keep guns out of the hands of kids, particularly those who are intent on harming themselves. And so that may be a place where we have some leverage in order to find common ground with folks who are really committed to making sure that people can retain their guns, but we still need to think about how we might be able to prevent adolescents from getting a hold of them.
I'm reminded of an interesting conversation I had with my daughter. She's the mother of 3 wonderful grandchildren. And her comment, she's a psychiatrist, her comment was, we have Mothers Against Drunk Driving. We don't have mothers asking whether or not you have a gun in your home when your child goes over to play in their house. The question of neighborhood safety and the opportunity to develop family safety as a mode for dealing with the question of the risk of guns, both for accidental injury and certainly related to suicide, may provide us leverage in ways we haven't had it before.
Well, I have an anecdotal story that I just spent the last 6 months at Cambridge University at the Institute of Criminology in England. And, you know, if you ask most Americans and most English, which is a more violent society, England or Britain or the United States, everybody says the United States. The fact is, national victimization studies show that about 1995 there was a crossover. In the late 90s and early 2000, in fact, Britain was more violent on almost every dimension except one, homicides. You were more likely to be raped in Britain, you were more likely to be assaulted, you were more likely to be robbed, but not homicides. The US vastly exceeded in homicides. Now, I don't think it takes a genius to know why. It's gun policy.
Darnell?
I think I'm a little bit less optimistic about gun control than I was just a year ago, you know, a year or 2 ago. I thought that after the drastic events in Newtown and other events like that, we would really get a groundswell of opposition to guns in the United States. And in fact, I have been a part of that effort on my own small part, Facebook, Twitter, contacting my politicians. I've written to all of my congressmen about it, and Dianne Feinstein in California even, telling her that I support her effort. But I just don't see any follow-up to that at this particular point. Somehow we just have shifted back into this absurd position of, oh, well, guns are a part of our culture, you know, they're going to be here, the Second Amendment protects them. And in the meantime, kids in the inner cities are dying, kids in schools are dying. So again, I was fired up a year and a half ago, you know, about what could be done about gun control, much less so now. Maybe some organization like this needs to take the lead. We have a little bit more leeway. Obama seems a little bit more tolerant of it than some other past presidents have been. Maybe somebody needs to sort of push it from the policy front again.
Yes,
one
sir.
question, one form of violence that was not mentioned, spanking of children. I wonder if you would comment.
Sarah? You want-
Well, I think that spanking is still a hot button issue in many communities. The AAP has come out with guidelines suggesting that children should not be spanked. That said, there is still an awful lot of spanking going on in our communities. I think in particular, the evidence is relatively robust to suggest that there is behavioral dysregulation and increased aggression, but I think some of the science of that research is really complicated by lots of confounding factors. So I think that that's still, in terms of what parents actually do in their homes, that's a complicated message for pediatricians to deliver to their patients.
One thing we talked to our pediatric nurse practitioner students about doing and talking to families about is around, if you come out with blanket statements like the science says, if you ever spank your child, you know, you're a bad parent, that those kinds of messages don't work. But the parents are hungry to know how to discipline their children in ways that are effective. And if you point out to them the science that says actually spanking's not that effective, that may have more credence, and it's not that you may not want to use it every now and then, because oftentimes you're talking to parents who say, I was spanked repeatedly and look, I turned out fine. So, you know, we have to be careful about our norms in this country, that we don't chip away at them, we don't change them by confronting people and say, what you've been doing for the last 10 years with your children is wrong. So those are the kinds of things that I think we have to be careful about the context of our messages in terms of helping families raise their children.
One might say, Jackie, that two skills that we haven't well embedded yet in our healthcare system are risk communication and motivational interviewing that cut across a wide range of these issues, and our healthcare providers are not well trained in either one.
Very good point.
I also think maybe we need to start getting outside of our silos. For example, the presentation about PTSD I found fascinating, and I've been keeping up with a lot of that. But I saw a National Public Radio spot on about a month ago saying that the rate of PTSD among kids who are in foster care is as high as returning veterans. So if indeed that's the case, you know, what we've got is a phenomenon that cuts across all of these approaches to the study of violence.
Very good point. Ken?
Ken Shine, Dr. Johnson, really appreciated the insights you provided, but beside the overall educational issues and policy issues, what do we know about interventions that help families cope? What do we know as educators about what we ought to be educating our health providers about in this regard? As practitioners, what should be done in terms of trying to do this? Could you give us some notion as to what might work?
I can give you, I think the evidence there is fragmented. We know that focusing on the family, that focusing early, that increasing parents' capacities to provide stable caregiving to their families is really important. And while certainly there's an educational piece around positive parenting, there's also a huge policy component to that, which is scaffolding families through federal policies to help provide employment, for example, to provide other kinds of social supports. In terms of what works at the sort of individual level, we certainly know that intervening with parents and kids together in multi-systemic therapy and other kinds of interventions certainly do work, but they're incredibly challenging to put into place at scale. So I think that we really need to be thinking about prevention as much as we're thinking about intervention. And most of that goes back to these building healthy children and what capacities can we put into place. The last thing that we haven't talked much about in terms of the capacities of caregivers is that we've talked an awful lot today about trauma. And I think that overall our efforts to put in place systems of trauma-informed pediatric care and primary care across the spectrum are really in their infancy. And this is a place where the healthcare system could invest in really fruitful ways to help toddlers all the way to the elderly.
To echo Sarah's comment, the addition of the concept of collaborative care in primary care is clearly a model which works quite well. The ability to reach that, in which one embeds behavioral health providers with primary care from pediatric to geriatrics, greatly increases the ability to reach populations, to identify them, and to deliver evidence-based care. we aren't yet there.
And we do have some interventions that work, for instance, in intimate partner violence that have been provided in prenatal care settings that both pay attention, and I think this is one thing that's important, to decreasing the violence, but also taking care of women's health in these kinds of situations. And as Bob mentioned, developing some sort of a brief screen, we have some, but actually implementing them for things like PTSD, for trauma, and providing care that is trauma-informed is some of the language that's being used. Let's take
And
one
just
question.
to add, Jackie,
yeah,
to
I'm
add,
sorry.
in our system, that has to be accompanied with incentives.
Yes.
So I believe in this past year, primary care physicians are now incentivized for screening for obesity as well as for smoking. There has to be an incentive that goes along with the systems that we build.
Absolutely. Let's take a question over here.
Oliver, Oliver Fine from Weill Cornell in Manhattan. One of the interventions in New York that the panel has not commented on is stop and frisk. A intervention that I believe is not truly associated with a decrease in homicides, but actually I think may be a traumatic experience for the millions of adolescents in New York that have been confronted by the police unjustly. I was wondering if the panel has any comment on that intervention.
Darnell, I think you started to talk about that a bit.
Yeah. One of my colleagues in New York, Jeffrey Fagan at the Columbia Law School, has done some fascinating work on this for years, not just in recent years, showing the devastating impacts that unbridled stop and frisk policies have on not just sort of the fact that these kids get locked up, but their propensity toward violence in the future. So we're actually generating more violence by locking the kids up and unnecessarily stopping and frisking them. So I think you have an absolutely valid point that should be investigated, but I think that the courts are now dealing with that quite well from my perspective. You know, we'll see what happens.
All right, we only have 1 minute left. I want to take one other question, and we'll see if people can weave in a summary comment as they answer. Yes, sir.
All right, David Vlahov, UCSF. So I'm going to ask two questions since our time is so short. And the first one, so you show some data saying that with watching video games, there's an increase in aggressive behavior. But one of the questions that Biden asked was, are you going to see more firearm associated action, I guess, with the video game? So that's one question. The other is that we're talking about treatment of people that are exposed to violence. But what's the state of the art, I guess, at this point on resilience, right? A lot of people that go into these environments seem to come out relatively unaffected. And so what do we know about that, and is that something we can share with other people somehow in community prevention at least?
Thank you, David. Raul, I'll let you take the first one.
Okay. Well, yes, we do know that there's a correlation between adolescents and children playing more violent video games and their propensity to use weapons. It's difficult to, it's much more difficult to, as self-reported, it's more difficult to get a handle with official statistics, so we don't have that data. More research needs to be done. But for example, Michelle Ybarra and I have a study that's about to come out in which the question was, have you carried weapons to school? And of course, the primary factor that predicts more than anything else is, have you been victimized? Kids who are victimized. But the second predictive factor that was significant was how much violent video games do you play?
I'd just like to add one comment about, particularly given Mark's chart this morning about the off-the-scale rates of violence among African American males. I think one of it's kind of ironic in a way that the relatively great amount of attention we have paid to family structure since the rates have started to escalate. Single-parent families, dysfunctional families, might have made us miss a very important dimension of the violence problem. I mean, he mentioned that many other countries have rates of assaultive violence equal to the United States. Australia, a lot of other countries have rates of assaultive violence equal to the United States or higher. That includes African Americans. African American male assault rates, aggravated assault rates, are not off the charts compared to some other countries. What is off the charts is their use of firearms to kill each other. So we're back to the firearm equation again. So I think, we're spending a lot of time now talking about developmental studies, how can we nurture kids better? That is very important. But if they have a gun and they aren't well nurtured, then it is more deadly. The violence is going to be more deadly. So we're back to the pivotal part of the equation, which is gun control.
I'm going to let Bob and Sarah have one word each about resilience.
Exactly. Thank you. So resilience has been underspoken of today. The vast majority of people do okay after exposure to any traumatic event. Understanding resilience requires a comprehensive look from the neurobiological level to the psychological level to the family to the community, and we have hints and some data at each one of those. There is a marvelous article that describes the principles of psychological first aid. It, in fact, highlights almost all we know about resilience by highlighting issues such as the ability to calm, connectedness, hope and optimism, efficacy, and safety. Let me highlight connectedness in a final comment. Bob Sampson did marvelous work looking at the strength of communities and protection from violence. We recently replicated that in a study of Florida following a natural disaster to show that communities that are stronger had lower rates of post-traumatic stress disorder. We know that soldiers that are in units that are cohesive have lower rates of post-traumatic stress disorder. And I believe there's sufficient data to say that strong families probably lower risk for bad outcomes of all kinds. How we build that kind of cohesiveness is a major target.
You'll leave it at that. Sarah says that was terrific. All right, I thank the panel very much, and I know Nancy's ready to yank us off of here.
So many thanks to this panel. I'm sure I'm speaking for all of us when I say I wish we had more time to explore these questions further, and I suspect we're going to have the same reaction to the next panel. Our format is going to be a little bit different, just in that I will be introducing the moderator who will introduce the panel, and I'm very pleased for this session, which is called Violence from Context to Policy, with an emphasis on firearm violence, will be moderated by Dr. Tony Earls, who is Research Professor of Human Behavior and Development in the Department of Social and Behavioral Sciences at Harvard School of Public Health. And I welcome Dr. Earls and the panel.